there's something that's not working in the way that we approach mental health care. What seems to be happening in mental health care is something that people refer to as the treatment prevention paradox. The more people are accessing services, so there has been more and more access to assessments, different types of treatments, interventions, more people getting mental health diagnoses. So the prevalence of mental health conditions has been expanding and expanding pretty relentlessly. And the amount of access that people are having to various types of treatments, whether they're psychological, social, or pharmacological, has also been expanding rapidly. And if what we were doing in the mental health sphere was successful, what you would expect would be at least a stabilization of the prevalence rates, but hopefully the prevalence rates would start going down because we would be seeing an improvement in outcomes. I've come across a lot of people who've been prescribed SSRIs, and in my experience, I have not come across anyone yet where this has led by itself to lasting change. ADHD starts out as a very rare condition called hyperkinetic disorder. When I was training as a child psychiatrist, I didn't come across any child with this condition. It was considered to be rare. If you had a learning difficulty, that would be an exclusion criteria. But then it goes through what I call a mutation of constructs. And at no point was there any new scientific information coming forward to tell you that there is something empirically in common with people getting the diagnosis that you can find in their bodies or brains. So it expands to include not just levels of activity, but also attention levels, and expands to 3%, 5%, and now up to about 10% of children.
Hey, everybody, it's Michael Shermer. It's time for another episode of The Michael Shermer Show, which is hosted by the Skeptic Society and Skeptic Magazine. To support our work, go to skeptic.com/subscribe. And if you really want to give us a little love, go to skeptic.com/donate. We are a 501c3 nonprofit science education organization, and dependent on your donation. So thank you so much. My guest today is Dr. Sami Timimi. Hopefully I'm saying that right. He's a child.
Absolutely perfect.
Yeah. Oh, perfect. Sami Timimi. Okay. He's a child and adolescent psychiatrist, psychotherapist, and fellow of the Royal College of Psychiatrists. He's published more than 150 academic papers and authored or edited over a dozen books, including Naughty Boys. Oh, I have one of those. Not really. Liberatory Psychiatry. That sounds good. The Myth of Autism. Oh, boy, that's going to come up today. And his new book is Searching for Normal, a new approach to understanding mental health, distress, and neurodiversity. So Searching for Normal. All right. So I love this subject. We've been following this since we started Skeptic Magazine back when Thomas Szasz was all the rage. You know, that mental health, mental illness is a social construction and all this stuff. Mm-hmm. And I remember when I was at Pepperdine University in an undergrad abnormal psych program, 1976, the teacher had us read this paper, Being Sane in Insane Places by Robert Rosenhan.
Classic
famously,
paper. Yeah.
He and his graduate students famously checked themselves into mental institutes and got themselves committed just based on saying just a couple of innocuous things. And then these psychiatrists and psychologists interpret everything they did in the light of this, well, they must be mentally ill. And I always thought since then, there's something different about psychiatry and psychology from, say, physics and biology of the classification of things. So maybe we just start there. How do you think about that issue?
Yeah, I think that is a good place to start because we have a lot of assumptions that have become part of the public narrative about how we understand what we refer to as mental health, states of distress. And the narrative that has been used has been imported from narratives or approaches that have been quite successful in a lot of areas of healthcare, in a lot of areas of medicine. But one of the things that has become clearer and clearer in recent years, and I'm not the only one who's pointing this out, a lot of authors from a variety of different backgrounds are pointing out that there's something about the outcomes of mental health care that don't track in the same way that you see the outcomes improving for a lot of physical health conditions. So outcomes have been improving for cardiac disease care, for cancer outcomes in terms of, for example, when I was a child, I think the chances of, if I was diagnosed with leukemia as an 8-year-old, the chances of survival was something like 20% into adulthood. Now it's something like 80%. These are the sorts of examples we have from a lot of the rest of medicine. But what seems to be happening in mental health care is something that people refer to as the treatment prevention paradox. The more people are accessing services, so there has been more and more access to assessments, different types of treatments, interventions, more people getting mental health diagnoses. So the prevalence of mental health conditions has been expanding and expanding pretty relentlessly. So if the types of and the amount of access that people are having to various types of treatments, whether they're psychological, social, or pharmacological, has also been expanding rapidly. And if what we were doing in the mental health sphere was successful, what you would expect would be at least a stabilization of the prevalence rates, but hopefully the prevalence rates would start going down, because we would be seeing an improvement in outcomes. So there's kind of universal agreement that there's something that's not working in the way that we approach mental health care. And most of the responses to that tends to be a kind of, well, I think of it as a bit like a one-eyed monster. We just keep asking for more. We just keep saying, oh, yeah, the reason we're not improving outcomes is because we need more services. But if the fundamental assumptions on which your services are built are actually mistaken, indeed, if they are part of the problem, part of the reason why we're not improving outcome, the simply providing more and more interventions, more assessments, more treatments, more diagnoses is likely to make the problem worse. And that's what's been happening. And that's because we have some fundamental assumptions, which you're hinting at, that don't track in the same way. So what we're calling mental health, all the definitions that we have one thing that they have in common. They're all subjective. Just think about trying to make a definition of yourself. What do we count as a mental health problem? Look at the World Health Organization definition. It's full of subjective concepts. So it talks about people being able to function as citizens, being able to contribute to their community, being free of distress, and so on. And all of these are subjective concepts. And because they lack what you might refer to as an empirical anchor is something that you can measure, that exists externally beyond the subjectivity of the person doing the diagnosis. So that allows you to categorize people into a case, into a category where they share something in the material world in common. So we don't define diabetes, for example, by reference to a description of how people feel, of the types of things that they might experience, like, going to the toilet a lot or fatigue, or we don't categorize it like that, because lots of things can present like that. Diabetes sometimes doesn't present like that. We categorize it by reference to blood sugar levels, because it's and then you can monitor treatment. You can see what the effect of treatments have on something that is measurable in some way. And you can then develop a scientific approach. You can develop, if you like, improve your technical knowledge around a group of people who share that in common. There's lots of complexities, lots of challenges. There's a whole psychosocial component with people who have long-term conditions, but you have a starting point. And this is where a diagnosis, which is a system of categorization based on understanding a proximal cause, makes sense. You want to make a right diagnosis because it will have a fundamental effect on choosing the type of treatment that you're going to do. But of course, in mental health, because we don't have these empirical anchors, all we're left with are subjective definitions. And these subjective definitions require some sort of interpretation of what they actually mean. And because they're subjective, they're very liable to being expanded horizontally by taking in, for example, lesser experiences of distress or taking in lesser examples of behavioral difference. But they can also be expanded vertically by adjusting the criteria of different diagnoses in order to bring them into different populations who haven't previously experienced. So, for example, ADHD starts out as a very rare condition called hyperkinetic disorder. When I was training as a child psychiatrist, I didn't come across any child with this condition. It was considered to be rare. If you had a learning difficulty, that would be an exclusion criteria. But then it goes through what I call a mutation of constructs. And at no point was there any new scientific information coming forward to tell you that there is something empirically in common with people getting the diagnosis that you can find in their bodies or brains. So expands to become, to include not just levels of activity, but also attention levels, and expands to 3%, 5%, and now up to about 10% of children. It then expands vertically, so people started talking about it being a lifelong disorder. Originally, it was conceived of as a developmental condition. In other words, the expectation most children would grow out of it. When it becomes a lifelong, you get this concept of adult ADHD, and you have to adjust the criteria. So they're no longer the sorts of criteria that you use in childhood. You develop whole new questionnaires and new ideas. So it kind of starts to revolve around things like instability in relationships, being disorganized, poor timekeeping. Those start to become. And then you expand it even further by introducing the concept of masking. So the concept of masking is the idea that you have the symptoms, but you're really good at keeping them in so that people don't notice the symptoms, but you notice them when you're out of social situations. And that enables it to expand beyond it being a predominantly male diagnosis to becoming a female one as well. So that's what happens when we don't have an empirical starting point. We have pseudoscience and scientism taking over.
Yeah, that's a beautiful way to sum it all up there in one short statement. I'm largely in agreement with that. I think a lot of this is pseudoscience or junk science or bad science or voodoo science, because it isn't like these, taking a blood draw. I bring to you my kid because the teachers think he has ADHD. You do a blood draw, you do a brain scan and go, oh, well, there it is. Just like, there's nothing like that. So this goes a long way to explaining, I think, I'm sure you're in England, but I'm sure you follow RFKJ's, expanding autism statistics where, it used to be 1 in 300, then it was 1 in 30, now it's 1 in 10 or whatever. I forget what the numbers are, but, it's like we have a crisis. It's a pandemic, it's something like a pandemic of autism and an epidemic of autism. And then so for RFKJ, first it was, the vaccines. And then Trump put him on it and said, we got to get to the bottom of this by September. So in September, he announced Tylenol, women taking Tylenol in the third trimester. It's like, really? I mean, is any of this necessary? Because it hasn't been expanding. I mean, there isn't an increase in autism. There's an increase in diagnoses because the category is expanded.
Yes, exactly. Autism is an interesting one, because it starts out its life as a very rare condition. So when it was first defined back in 1943 was the first sort of recognized use of the autism as a diagnosis. It had been used in medical literature before to denote what's called an autistic state of mind, which is probably the most accurate way of thinking about autism. It's a state of mind where you've withdrawn from the world. So it was often used to denote a state of mind of people who are psychotic. But anyway, the first time it's used, 1943, the classic paper was with children, all of whom had moderate to severe learning difficulties. So it starts out its life with a very obvious and tangible connection with very likely neurological compromise. And so it gets its reputation, understandably, as a condition that is brain-based and that's associated with some pretty important and profound neurological compromise that makes it difficult for you to expect the people who get the diagnosis to be able to function independently in their life. So they were people who required considerable amount of educational, social, and clinical support. They often had other physical conditions such as epilepsy or chromosomal disorders. And so it starts out its life very much in that group of children. And the early studies give a prevalence rate of somewhere between 1 and 4 in 10,000. So we're talking about 0.01 to 0.04. So these were the studies that were done in the 1960s. But now something pretty amazing has happened to it, because now you can go from, if you like, speechless residents who require 24 hours care, who are not going to be able to function independently in their life, and they're going to need a lot of supports, right up to Elon Musk. So that's the full functioning of human spectrum.
Yeah.
Now, you can't tell me that Elon Musk's needs is going to be the same as the person who's requiring. So in terms of its utility,
yes.
just in those terms, forget even its scientific validity. In terms of its utility now, it tells us very little about what the needs of any particular person who gets this diagnosis. When you have a functioning range so broad, so wide, then you have to ask the question, which I have been asking, has autism got past its use-by date? I used to say sell-by date. Maybe I should say sell-by date, because it has also become a commercially very successful construct. A lot of people seem to be attracted to the idea. This is the whole thing. Other thing that I'm discussing in the latest book, Searching for Normal, is the degree to which the mental health industrial complex, as I label it, has merged into identity politics. So people are now seeing in themselves an identity revolving around these labels.
Oh, yeah. We just did a study through my Skeptic Research Center on and finding some significant percentage of people who identify or sort of, take great pride in their victimization of, having some sort of mental health problem, and that they identify that. I mean, they define themselves by this. It's like they're
I
anyway.
saw that reference on your website.
Right. Yeah. Do you think some of this could be driven by the shift from the stigmatization of being mentally ill, oh, she's crazy, to it's just a medical problem? You wouldn't make fun of or demean somebody who has cancer. You would say, oh, they're a victim of this biological problem. So mental health is a biological problem, and that reduces the stigmatization, and maybe that's some of the kind of cultural drive to be more inclusive that way.
The whole issue of stigmatization is quite an interesting one, because there has been this idea that we need to destigmatize mental health conditions and psychiatric diagnoses, and that one of the big problems has been this stigma. So people are not coming forward, they're suffering in silence, etc., etc. But if you look at the studies that have taken place around the models that are most associated with stigmatizing attitudes by the public, they have universally been associated with the idea that mental disorders are illnesses just like physical illnesses. That in various types of studies has been associated with a sense of fear because it is associated with an idea of potential unpredictability of the person and a desire for greater social distancing from that person. So it's the promoting the illness model of mental distress that is most associated with stigmatizing attitudes, even if the people themselves feel that it's been helpful and destigmatizing to them. The model that is most associated, paradoxically, the model that of thinking of mental distress as the consequence of bad things happening to you, basically, as the consequence of adversity, is most associated with the likelihood of an empathic response and often a desire to help. So the model that we've been promoting that we imagine would be more destigmatizing is actually the stigmatizing model. And this is also where I think we need to be careful in terms of people need to go in with their eyes open when they decide that they want to identify with this or that condition. Whatever you say about, adjustments and so on that could be put in law, if you have an employer and they have to choose between somebody with a diagnosis of anything, autism, ADHD, anxiety, and somebody who doesn't, they'll find a way to make sure. And so what we're seeing is that the rates of people having to live on disability allowances, on various disability claims, mental health has become the number one reason. And so the category of mental health as the reason for claiming disability living allowances of various types is the one that's been rising and rising, while most of the other ones have been falling. Back pain used to be the most common one. Depression is now the most common reason. And you're seeing this across Western societies.
Is that not a product of the healthcare system that in order to get reimbursed from the insurance company, I have to have a number of the category of what I treated, and then you send that in and they get paid?
Yeah. There's, we've embedded this idea that we have these diagnoses into a whole administrative system. And that's why I call it the mental health industrial complex, because it's got a whole ecosystem of products, of bureaucracies, of things that seem to be actually making us as a population, contributing to making us as a population sicker in many different ways. And I think, the concepts that we use are part of that machinery that's making us sicker.
Let's talk about subjective evaluations of these things. When I go to the doc and they take my weight and blood pressure and so forth, and if I'm in pain, my doc will say, well, I don't know, on a scale of 1 to 10, Shermer, how bad is your headache? Well, it's an 8. All right, well, let's try this. And then I come back and, well, it's a 4 now. Well, it must have worked, right? I mean, so they use these subjective, there's a whole industry, the study of subjective well-being, right? Happiness. I mean, there's just endless books. I have them stacked up over here.
Right.
But there's no blood draw or brain scan that go, oh, look how happy you are or how sad you are or whatever. You just ask people, on a scale of 1 to 10, how, or you do the little beeper thing. I guess they don't do beepers anymore. They must have apps, how happy are you right now, this hour, right? And then you track it, all that research. Okay. But they're measuring something. I mean, they're trying to get at it. This is it is a definite problem, unlike physics or biology. I mean, we have that internal state that I don't know what, it's the other mind's problem. I don't know what's going on in your head. I have to infer that from what you tell me and I observe. I mean, what else do you have? If somebody comes to you and says, Doc, I'm really depressed, I'm sad, what do I do? And then, so you got to do something, right? So you have to some kind of measure or something you try to get some objectivity to it.
I think that there is something important about us being honest with people and being honest about our limitations. I kind of, what you've highlighted is that there are problems with this issue of subjectivity that is there across healthcare, and they really crystallize in psychiatry. And if psychiatry was more honest about what its area of expertise really is, we as a professional group and as a professional body could be so much more helpful to the rest of healthcare that has also to grapple with these issues. And you've just given a good example about pain. Pain is, many people categorize pain as an emotion. It probably is an emotion. So we're dealing with these things that are one way of explaining this or helping others understand what I mean by that is that we have more than one system of knowledge in the way that we can understand and interpret the world. So you take something as simple as an apple. There are many things that you can say empirically about an apple that you can study scientifically to increase its yield, to decrease costs of growing it, transporting it, pricing it. All of this information, very useful to farmers, to grocers, and to consumers. None of that is going to tell me what it's like to eat the apple. That is an experience that right. I can only discover by eating the apple.
Yes.
So that belongs,
Qualia.
That belongs to a different type of knowledge system. And furthermore, I don't know what it's going to be like for you to eat that apple.
Mm-hmm.
I might offer you an apple and you'll eat it and you say you like it, but you might just be being polite to me. I don't know.
Mm-hmm.
So even our capacity for really empathizing with another person's predicament and another person's experience is always going to be limited. But one of the things that we have to be aware of is when we enter into that realm of experience, of subjectivity, we are dealing with us as humans. We are meaning-making creatures. This is the area of meaning-making. This is the territory of, if you like, I think of psychiatry and psychotherapy as a bit like the philosophical branch of healthcare, because we're trying to look at what framework of meaning-making is going to be the most helpful. And so one of the ways I think about situations like the one you described, somebody comes to me and you're already using a word that has inserted a meaning-making framework. You use the word depression, that they're very depressed. That's already inserting a word that's been taken out of the clinical world and has become popularized like many others, which tells you the extent to which we're imposing systems of meaning on experiences that are already taken out of a particular context. Because when you talk about depression, you've turned an experience into a symptom. And there's always a danger when you turn experiences into symptoms, because what we do with symptoms in medical terms is we think of symptoms as something that shouldn't be there, that's something that's wrong with us, something that we need to find a way to suppress or even better get rid of. But actually, this might be a system of meaning making that might make it more likely that that problem will start embedding itself in your experience without you realizing. Because if I diagnose you, for example, with depression, I prescribe something, and if that actually doesn't help you, or even worse, if you feel that it has helped you, but a few months later it's coming back again, So you're back at the doctor. Each time you go through a process like that, and you've conceptualized this as a symptom, it can strengthen that sense that there's something inside you that's really beyond your ability to handle, that's more severe. And this leads us down the route of you becoming a chronic patient, or even worse, someone who is then categorized as treatment resistant. And this is something that's been happening across psychiatry. We've been creating chronic patients because there are different ways of interpreting that experience. And that experience can be interpreted without minimizing it's really important to validate people's feelings. But one way I think of, for example, what you described would be that you have a state of mind. And the thing about states of mind is that states of mind, I liken them to the weather. Any dynamic system has multiple inputs coming from multiple directions. And so with weather systems, it's really hard to predict what's going to happen to that weather system in the next couple of days. We're going through a period where there's a lot of rain and a lot of grey clouds around at the moment. Just a few days ago, the weather forecast said to me that it was going to be dry today. Actually, it started raining about 4 o'clock and hasn't stopped since then. So dynamic systems are very hard to predict. But the one thing you can predict is that they will change. So using a system of meaning making that says that you don't have a broken brain, and particularly using a system of meaning making that says that as human beings, the way we're built is when bad things happen to us, we feel bad. And that we're likely then to focus when that state of mind takes over, we're likely to continue to focus on things that remind us of how bad we feel. So the way I work, and I've worked with, young people in really awful states of mind. And the one thing I try to keep alive is the idea that the one predictable thing is that you will change. What I can't predict is how that will happen, when that will happen, but I can predict it will happen. And I've seen it again and again and again. People do find a way out, but they do find a way out. They're much more likely to find a way out if you keep that hope alive. And if you don't create an idea that they've got some fixed, something going on with them that's broken, and that they have no capacity to influence.
Right. So by slotting them into some treatment program that doesn't actually work, you're I guess preventing that change from happening naturally, organically, or however it would have happened without that treatment. Is that your point?
That's one of the points. Absolutely. I think there is. I quote some of the studies that say that people who are left without treatment, the recovery rate is somewhere between 70 and 80%, and that drops to around 50% when they are treated in terms of longer term. If you look at outcomes, this is with people who are presenting in what we call depression. So that is part of the story.
In terms of what's the problem to be solved? Okay, so we can't get at these internal subjective states, but we can see the results of behavior. Do you have an addiction problem with porn or gambling or alcohol? Well, I don't know. If your spouse leaves you and you lose your job, you probably have a problem. If not, you probably don't have a problem. And so I guess it depends on the behavioral outcomes and consequences for your life, for flourishing.
Yeah, that there are many different ways to approach phenomena. So a diagnostic system approaches phenomena with the idea that there is a cause proximal to what's happened, so that your experiences are caused by something. that works very well if you have something measurable and you can bring that scientific framework. And the meaning-making system is based on material reality. Other phenomena, you're not going to find a cause, or finding that cause is so complicated. So I liken it to peeling a never-ending onion. And I talk to a lot of the patients and families I've seen over the years to say, look, actually, we could waste a lot of time trying to figure out the cause of why you're feeling like this. And I say it's a bit like peeling a never-ending onion, because you'll think of one thing and you'll peel that layer away, and then something else, you'll remember something else, and then something else, because we're made up of so many interacting parts, from the various personality traits that we inherit, from the state of the parents when you were born, from the friends you meet, from the things you've heard on social media. You know, there are so many different things. But that's not the only way to approach phenomena. Sometimes a better way to approach phenomena is to talk about its purpose. So instead of looking backwards, you're looking forward. What is the purpose of this? And what would you like to change? Maybe we don't need to understand the cause, but I think it would be helpful to understand not getting rid of something, but what would you want instead? So you get a lot of this kind of, you could think of it as a kind of yin and yang in the world of therapy, in the world of intervention. You know, on the one hand, you've got the kind of problem side of things, which is weighing and keep making your life out of balance. And the traditional approach is you call these symptoms and you try and reduce the symptoms to make life better again. But then there's the other way of approaching it, which is that there is the problem side that's weighing you down, but there's also the strength side. And what's going on here? So some of the most resilient people I've met have been people who've come to our clinics. Because if you're feeling really terrible, but you still manage to get up to come to an appointment, that says something. If you're still able to do some sort of functioning. And that is, you know, spending a little time focusing on this bit that might go missing. I'm one of these people who thinks you should never try and teach resilience. That's a stupid thing to do. Resilience is something you discover. You can only understand what it means to be resilient by going through suffering and finding a way to survive. So a lot of the time, what I'm working with in a meaning-making system is what relationship with your suffering is going to be most helpful for you to understand. There's many aspects to suffering. Suffering is a human condition. It's a delusion to imagine that we can get rid of suffering from humanity.
So back to my, thought experiment of okay, doc, I've come to see you. I've lost my job. My spouse left me, and I've decided maybe it's me and not all these other people. What should I do? What can I do? Help me. Where do you start?
That is a question that is going to be dependent on the specific person and the specific situation that they're in. So I would want to understand things like, what would looking better look like for you? So, for example, these are just some of the different ways that you can work with people. I'd want to validate and appreciate their situation and how they're feeling. You must be careful not to minimize. But I'd also want to understand what change looks like for them. Because when people get immersed in a problem, there's something that we can refer to as, so one way of thinking about this is, in our meaning-making attempts, we make up stories to try and understand the situations we found us in. And the stories that we tell ourselves are going to be a mixture of things from what we've heard, from the stories we've heard about us, from what other people have been saying, maybe from watching a film, watching media. I mean, social media is having a big influence on how people understand themselves and their experiences. But eventually you're constructing a story. And when you're really struggling, the story you construct, you can refer to it as a problem-saturated story. And the thing about a problem-saturated story is when you start focusing on a problem, you get this kind of emotional flow that keeps noticing those aspects of the story that confirm how you're feeling and how you're interpreting the world. And so sometimes one of the tasks is to help somebody look at a different way of constructing a story. So a lot of the times I'm trying to look for a different framework of meaning making. So there's more to anybody's problem than just the problem. They might have had problems before. How did they?
So you're really talking to them about the larger picture. But what if I say, Doc, can you write me a script for an SSRI? Give me an antidepressant. I need something to kickstart the engine here.
What I explain, because I, again, work with under 18s, what I explain to people is the evidence is, particularly in your age group, that these medications do not have better outcomes than a sugar pill, in according to the studies. However, they come with a range of side effects, particularly long-term ones. People can become dependent. In other words, they experience withdrawal symptoms after they've been on it for a while. And it actually, there's an increased chance compared to people on sugar pills that you might act on suicidal feelings, and also an increased chance of outbursts of aggression. So I explain to them the evidence. And I say that my clinical experiences matches this. I've come across a lot of people who've been prescribed SSRIs. And I've prescribed SSRIs. I'll get back to that in a minute. And in my experience, I have not come across anyone yet where this has led by itself to lasting change. I've come across quite a few people who have a period where they feel better, and I now understand that is likely to be what I call enhanced placebo effect. Because you feel a bit different, you interpret it as getting better. Trouble with placebo effects, they tend not to last. So what I then see happening is after a while, they'll go back to the doctor or come back to me and say, it's not working, can you increase the dose? Maybe we need to try a different one, etc., etc. But what I do say to people, okay, I've explained to you the evidence. Are you sure that you really still want to try this? And some people say, yes, I do. I still want to try it. I've heard great things about it. Okay, I will do that, but on one condition. I need you to recognize that this is not the treatment. Okay. I use metaphors or analogies a lot of the time in my practice. So I say this would be a little bit like if you injure your knee, you might take painkillers. The painkillers is not going to heal your knee. It's the physiotherapy that you're going to do afterwards, and the painkillers might help you with the physiotherapy. So you need to understand that a drug doesn't think, it cannot make decisions, it doesn't initiate action. Now, if you do have a period where you feel a bit better, what is it that you're going to do? And so I insist that you have to come up with a plan about what you're going to do if you start to feel a little bit better. What can your parents do? How can they support you? So I talk about this. You'll have a limited window of opportunity, but the things that's going to make the long-term difference, that's going to help you recover, is going to be what you are able to do if you start to feel a little bit better.
And can you do that if they start to feel a little bit worse? Like, just stop doing that. Like, I have thoughts bubbling up, and I get angry, and then I lash out at family members, friends, people at work, and this is causing me a problem. Can you just say, well, just stop doing that? Well, it sounds like you should be able to do that, but maybe you say, well, I can't. Well, you're not doing it right now, so apparently you can control it. But but later it bubbles up, and I can't. I mean, isn't something like cognitive behavior therapy, isn't that one of these tools? Like, all right, when you feel the thoughts bubbling up, these emotions, count to 10 or walk outside, or I don't know what the strategies are to kind of maintain your own self-discipline to control those emotions.
I'm a bit rude about cognitive behavior therapy.
I know, I read that in your book.
Yes.
But isn't that one of the few things that works?
The evidence on, because I've been looking at the psychotherapy, because I'm also a psychotherapist. I've been looking at the psychotherapy outcome literature for a long time, and there is no model that has demonstrated any superiority in outcomes by technique compared to other particular models when done in properly controlled comparison studies. And the other thing is, since the early days of doing outcome research, which was around 1950s, 1960s, the sort of research that we now recognize using a comparison group and an intervention group, there has been no increase in the percentage of people who improve through a therapeutic intervention. In other words, technically speaking, we've not made any progress. So the idea that we have psychotherapy technologies is a false one. The reason why cognitive behavior therapy seems to be the most prominent one is what I call the phenomena of, excuse this for sounding a little bit rude, but I've got a bigger one than yours. It's the fact that the early cognitive behavior therapists came up with a lot of the rating scales that we use in research on depression, anxiety, because it focused on thoughts, and so it was much more amenable to questionnaire type research, and so it became popular in that sense, and it's the approach with the most publications. That's
interesting. So it's an artifact of how the system developed. Is there any evidence that going to a psychotherapist or a professional counselor, whoever, is any better than just my talking to my friends? I mean, let's say I'm having marital problems. I'm not, but let's say I am. And so I go to a psychologist here, and I talk to this person an hour every week for a couple weeks or whatever. Or I just go out on a bike ride with my buddies, and we chat about our spouses and our marriages and stuff like that, which also makes me feel good. Is the problem with what you're saying is it's an N of one. Maybe if I'd never gone to the psychologist and I just went out with my buddies, I'd also feel better.
I think there is some evidence to suggest what you're saying might be true at a population-based level. So at a population-based level, we've become more and more enamored with individualized interventions, therapy, pharmacology, self-help apps, etc., etc. So this goes back to earlier in our conversation when I talked about the treatment prevention paradox. That model of individualizing suffering and increasing access to various types of treatments is not associated with improvements in mental health at the population level. Quite the opposite. And that might be because we're actually encouraging an approach to mental health that shifts us away from, we are social animals, shift us away from the importance of relationships in our lives and the resources that, because a relationship with a therapist might be extremely helpful in certain ways, but it's not going to make up for real life relationships. Those are the ones that are going to be a lot more emotionally meaningful to you and a lot more of your resources on a day-to-day level. So it doesn't necessarily help you build up that social capital unless you're engaged in a therapeutic approach that is aware of that and is aware that the important things that happen in people's life happen outside the consulting room. But therapy can be helpful, and I've seen it being helpful, particularly for people who are presenting with a. So I think this popularizing of mental health interventions is probably unhelpful for now. It's spread to kind of what you might consider mild, moderate, and the sorts of struggles that people have been having for thousands of years as they try to make sense and try to live a meaningful life, I think. But for those with more severe presentations where their functioning is really impaired, where I think there's an important role for how therapeutic interventions can help you reimagine and what's going on. And as I say, I've seen it being helpful in terms of, but the way I think about therapy cannot be anything other than a co-constructed process. It can't be a process in which I have the knowledge and I impose it on you and tell you how to recover. It has to be something that you figure out in that relational space. And it can be really important in keeping hope alive. It can be really important in preventing people from killing themselves, for example. So there is an important role for therapy, but it's been industrialized at a scale, again, going back to this kind of mental health industrialized complex. It's been turned into something that's you give to people, you prescribe to people as if you're prescribing a pill. You prescribe a course of therapy, and you send your insurer, I'm going on this course of therapy, and I have to have 12 sessions or whatever it is.
Yeah. I had a friend, Mark Edward, who was a magician, and then to help his income, he worked with the Psychic Friends Network, right? So he's a telephone psychic. Anyway, then he became a skeptic, decided, maybe that wasn't the most ethical thing I could have done. But basically, he said people called on nights and weekends. They were just lonely. They just really wanted somebody to talk to. Yeah. And all the other bullshit about candles and crystals and think this, thought of it, that's all just dressing. They just wanted to talk my life, my career, my marriage, this kind of basic human stuff. So maybe there's just, the atomization of society. Social media doesn't seem to have solved the problem we thought it was going to connect to people. So I want to get your thoughts on, that recent books on this by Jean Twenge, Generations, and Jonathan Haidt's The Anxious Generation, and so on. There does seem to be a genuine spike, I assume you would agree with this, in suicidal ideation, cutting, depression, anxiety amongst teenagers in the last 10 to 15 years. Assuming that's real, what role do you think social media and fear of being left out, fear of missing out, all those things are contributing to that?
There's another book recently, called something like Kids These Days.
Yes.
And
yes. It just came out.
If you come across it, and they make an interesting point, which each generation discovers and comes to the conclusion that the next generation are in big trouble, and they're lazy, they're feckless, and the whole world is going to go to shit. So there is a degree of that happening, I think, with the panic around social media. That it, of course, it has an impact. I mean, that is something quite new, and it has an impact in a number of ways. And I think it is harmful and can be harmful. So one of the things that I think has happened with social media, it's turbocharged what you might call social contagion. Ideas are spreading, and some of these ideas are deeply unhelpful. And this is one of the areas where ideas about mental health and mental illness and things like ADHD and autism and self-identity and this being a superpower, and the whole kind of mental health conditions becoming part of your identity, that's kind of come out of this role of social contagion. But the social media didn't give you the concepts. The concepts were actually came from branches of academic psychiatry, in particular, in collaboration with pharmaceutical industry, etc., etc. So it's important not to conflate that. But the other thing about social media, which in some ways I find interesting, and again, there's some evidence that for some kids, if you can get better controls on it. One thing that's happened is sociologists refer to this as the domestication of childhood. So children used to have a lot more unstructured time, where they would be far, would move a long distance from where they live without adults looking over what they do. So, I mean, I remember growing up, so that there was a much livelier kid culture where you made mistakes, where you got that rough and tumble, where, you sort of discovered things, boundaries, you experimented, you discovered things about the world, and they're not all, they weren't always good things. There's sort of things that your parents, you didn't want your parents to see, etc. In the domestication of childhood, we're in an era where there is a lot more scrutiny and monitoring of what kids do. So even sports now, I mean, when I was growing up, you'd go down the park, in this country, you'd kick a ball around and play soccer, with your friends, and make up your own teams and put down your jumpers for goalposts, things like that. So, but children from the age of 6 and 7 are organized into these mini leagues, so this domestication of childhood, how do young people discover a place away from adults prying, where they can have some of their own kid culture? And there is an argument to say, in some ways, they've discovered it, whether that's good or bad, in social media. So I think it's easy to exaggerate the negatives, and there are a lot of negatives.
I agree. I hadn't heard that phrase, domestication of childhood, yet. Haidt calls it the coddling, helicopter parenting, all that stuff. Yeah, absolutely. So I raised my daughter in the 90s, and now I have a son. He's 9 now. And it's completely different now. I mean, now everything is programmed. Play dates, parents have to email and call each other to set up the date and what the hours will be and where we're going to meet. It's just crazy compared to my childhood in the 60s. Like, what? And then...
Yeah, where you'd go and knock on the door of your friends, see if they're in.
Yeah. Can Rich come out and play? Yeah, here he is. Yeah. Okay, yeah. So, but also, the intervention into normal conflicts. I'll just give you a recent example of my little guy is, pretty physically active, and the other guys they're very different from the girls, and they kind of wrestle a little bit to get out of control. Things escalate a bit, and then 5 minutes later it's done. But now what happens is the teacher intervenes, or like, okay, now we have to talk about it. We have to have a meeting with the parents. We're like, why? And my little guy is like, what do we have to talk about? It's over. I mean, everything's fine. So the concern is that we're not letting them resolve conflict on their own. And when they get to become young adults or teenagers, they're not going to have the skills because the parents have been solving the conflicts for them.
A colleague psychiatrist and friend, an Australian psychiatrist called John Uridini, wrote a lovely paper which got him in a bit of hot water at the time. This is a few years back. The title of the paper was "Let the Children Cry," which I think says it all.
That's a great title.
What he was saying is that the role of parents, carers, teachers is not to save children from struggle, from conflict, from upset, from distress, because you can't develop psychologically if you are not allowed to find your way and experience that these things are survivable. The role of parents, teachers, carers, etc., is to be there, is to be patient, to let them know that you're there, that you're, and to pick them up when they fall, but not to save them. Let the children cry. Don't be scared of distress amongst children. This is how they learn. This is how you grow up psychologically.
Lenore Skenesi's Let Grow movement for children.
Yeah.
You know, she was once declared the world's America's worst mom because she let her kid take the subway to school.
It's incredible, isn't it? How did?
Yeah.
Yeah.
Yeah. How did we ever make it out of childhood?
Well, exactly. You know, I mean, parents have been, you know, kids have been growing up and parents have been parents for thousands of years.
Are you following the change in like drug use and pot? There's stories today about the increase in the percentage of THC in pot. It used to be like, for our generation, it was like 1-2%. You get a little high, have a brownie, whatever. Now it's like 20, 30, 40% THC, and that this is not at all like what it was for us, and that this could be driving some of these mental illness problems or behavioral problems right off the headlines here. As you know, Rob Reiner and his wife were murdered in their bed by their son.
Yeah, no, shocking. Yeah.
Yeah. I mean, apparently he went, and so now the conversation, we don't know the details yet, but the conversation is around he was in rehab like 17 times in 7 years. I mean, what does that tell you as a psychiatrist? If you're going to therapy, you know, the rehab 17 times, something's not working.
Well, exactly. Yeah. That's, I mean, rehab and addictions, it's a complicated area, isn't it? I think there's evidence to suggest that the average, I mean, this is going back a few years, the average is about 7 times before somebody actually, you know, going, you know, a rehabilitation program about 7 times before they finally kick whatever habit. Yeah, habits are very hard things to kick. But the, I mean, there is a well-documented association between things that cause hallucinogenic and illusions, you know, that really distort your perceptions, and the likelihood of future, you know, the more severe end of mental health difficulties, including psychosis. And it kind of makes sense because these substances, particularly things like THC, they kind of crack the world open in terms of you seeing the world in a different way. So they introduce your mind to an idea, because I mean, people can have very strange thoughts, but very strange experiences involved in those thoughts. They open the idea that the world is not as you think it is. So, you know, paranoid ideas can very easily creep into that when you're having an experience like that.
Right. So that could lead somebody to think they have to kill somebody else for some bizarre reason. Right. Well, then that takes us into the more serious mental illness problems of the psychoses like schizophrenia. I mean, I think you opened your book with, you know, that we were going to cure this problem like a quarter century ago. You know, we're on this, you know, and really we've made pretty much no progress at all.
No.
Clearly, this can't just be a socially constructed idea. There's something wrong with them. Maybe we can't see it on a brain scan or a blood draw, but there's something chemically wrong. I mean, am I wrong about thinking that?
Well, we haven't found the chemically wrong thing. The strongest association, and it is an association with any of the mental health conditions, including the more severe end ones, is adversity of various types. I've worked with a lot of young people who've had what you might refer to as perceptual abnormalities, which we tend to think of as psychotic symptoms. In other words, hearing voices, for example,
hallucinations.
That are not there.
Okay.
Yeah. one of the ways of working with people like that is that is instead of thinking of these as symptoms and experiences that they need to suppress or get rid of, thinking of them as human experiences that may relate to something that's meaningful for them. Because in psychiatric approaches, we tend to think of things like that as a way of categorizing what type of symptom do you have. But for the person themselves, so we think about the form of their experience, but for the person themselves, it's the content that's terribly meaningful to them. So there's one of the ways that, of working, which is you take, for example, a auditory hallucination, and you try and personalize it. So you ask questions like, is this a male or female voice? Do you recognize the voice? Is it your own? Is it somebody you remember? Who do you associate it with? How old do you think this voice is? What emotion is this voice showing? What do they actually say? Who do you think they're referring to? Why are they saying? So you kind of turn them into, and then it's about how much power do you think this voice has over you? You know, why do you need to listen to it? What happens if you don't listen to it? Well, it shouts at me and tells me, you know, this and this is going to happen. So it has a lot of power over you. But what might happen if you? So, for example, it might be. You know, I've worked with people where I look at their face and realize the voice is talking to them right now.
Really?
And I say, yeah. And I say, what is it saying right now? And they won't tell me. I say, I know what it's saying. I think it's telling you that you shouldn't trust me. Why do you think it's saying to? And then I talk about how these voices represent part of ourselves. They're often related to. So I trying to offer a framework of meaning. They're often related to things that have happened to us that we've been emotionally overwhelmed from doing. And in a strange way, it's trying to protect you now. It's trying to say, don't trust me, because in the past you've experienced trusting adults around you has led to you being. So the people I tend to see who have these experiences have often had pretty awful histories or something. You know, so,
but it's really kind of an extension of our normal hearing voice. I mean, I hear voices in my head, sort of. I mean, it's just me talking to myself.
We do.
Yeah.
Yes. Yeah. We have versions of that experience, and a lot of the population do have versions of that experience. There's some really interesting anthropological studies looking at the experience of voice hearing across the world.
Yeah. Do you know? Let's see. Is it Catherine? Lerman, Lerman's book. These are religious people who hear the voice of God. But this isn't like Joan of Arc or Saul on the road to Damascus becomes Paul. And God told me to. No, it's nothing like that. It's just the average religious person saying, you know, I'm just going through my life and God told me this. Did you actually hear a voice? Well, no. I mean, I'm just kind of interpreting stuff that happens in the world. And we all do that to a certain extent.
Yeah, we all do that to a certain extent. But in this study, for example, there was this study that looked at people who were hearing voices in a number of different countries. And the ones in America and the UK, I think, were much more likely to interpret the voice as something that was a sign of an illness, and they felt very persecuted by the voice, because that's the model that we use. Whereas the one that sticks in my mind is this. They gave a case example of this woman in India who hears various voices, and she gets irritated with them. She sometimes has arguments with them, but she's not scared of them, and she gets on with her life. So it had a different quality of relationship, and that's one of the things I try to do in my therapeutic work. And it is an important decision about whether you might use medication. Again, medication is not the treatment. It can be an important adjunct. What medication does, we've misnamed it antipsychotics. It basically is something that reduces the intensity of your emotions. So people start to feel flat. And that can be really important, because if part of your hallucinations is telling you, or part of your experience and your intensity is telling you you're in danger, you need to go and kill someone, or that you need to kill yourself now to move on to a better world, it can save someone's life to have that intensity reduced. But if you don't do a work around the meaning making framework, you're in danger of inducting that person into a long-term struggle with these experiences, and that's how you create the long-term patients.
Yeah. Do you know about the sense presence effect, or sometimes called the third man factor? These are like solo alpinists and climbers or sailors, people that travel around the world by themselves or whatever. They sense a presence in the tent with them, or on the ropes on Everest or whatever, and they talk to this person.
Yes,
and there's lots of accounts of this. It's something
it
about
seems,
being alone, anxious.
Yep.
Maybe it's not just oxygen deprivation, because it happens at the solo sailors at sea level.
Yep.
So there's something else going on there.
Now there's lots of stories of people who, for example, get lost somewhere and don't see civilization for weeks. There's that film. Is it Castaway with Tom
Castaway,
Hanks, which is based on a true story.
Yes.
This is a very common phenomenon. People who spend extended times on their own start to hear voices.
Yes, and Wilson, the volleyball, is his good
That's
friend.
It. Yeah,
right. He imbues it with essence.
So there's a psychotic experience.
Yeah, but it's not psychotic. That's kind of normal.
Well,
that's your point, I guess.
Exactly. It is part of the spectrum of human experiences. There are some more troubling ones. So when people are what we refer to as thought disordered, where it's very hard to have some sort of conversation with someone, because they can't actually organize their thoughts in any coherent way. That's that I think might have a much bigger organic, and we have discovered a few things, such as there's a rare condition. It's maybe not as rare as we thought, but it's autoimmune encephalitis, anti-NMDA autoimmune encephalitis. So that's something that you should, and that's much more likely to present with a kind of a thought disorder. People finding it hard to string together something coherent.
Oh, so, that's another one that's been in the news. Ketamine. What are your thoughts on that for treating these kinds of? Yeah.
That's such a dangerous, that's a very dangerous drug. People do die from that. They get all sorts of awful side effects. And the evidence is that the effects of it are quite short term. There's not been any study that's shown that it leads to any lasting effects. And so what tends to happen with any of these types of interventions that give short-term relief is they start talking about maintenance ketamine, that you have to go in for your ketamine infusion, every week or whatever it is to keep it at bay. That's a very, very dangerous new line that we've gone down.
I guess what you're pushing against is a system that wants to operate like the medical system. That's been your point here, in which, to be sympathetic to people, let's say, I come to you, my child is having this problem. Please help me. I don't want to just hear, well, just stop doing that, or, just tell them to quit doing that. It's like, well, I tried that. Come on, help me. Give me something.
Yeah, I think, and it's very hard for us as doctors in particular because one of the things that I've done a lot of training in all sorts of different contexts, but including for a lot of trainee doctors. And one of the things I say to them is, please don't burden your need for them to get better. Don't burden your patients with that. It's a kind of a bit of a God complex. We're set up socially as having the answers. As you go and see the doctor, they'll figure out what the problem is, and they'll prescribe something, hopefully, that will take that problem away, that kind of technical fix. And this is an issue for a lot of medicine. And this is an area where, if psychiatry wasn't so unnecessarily insecure about its status, instead of trying to copy the rest of medicine, which we're going to do badly because we don't have those empirical measures, empirical anchors, this is the sort of area of medicine where we could be offering the rest of healthcare a bit of wisdom, really, to know a bit better how to deal with your anxiety and know a lot better the importance of not doing something, not just of doing something. They say the best surgeons are the ones who know when not to operate.
Oh, wow. Right. That's a great analogy.
Yeah. So we also need to be humble. We need to understand that there are areas where we don't have the solution, and we have to be patient. We have to be patient with people. And the problem is when we fall into this trap of wanting to support somebody's sense that we have the idea and we should be doing something, is that if we do something and people don't get better, we're going to get more and more interventive. So we're going to prescribe more, and eventually we're going to blame the patient for them not getting better. So we will transfer that sense of failure that we're trying to deal with because our interventions aren't proving to be helpful, which is a very common thing in psychiatry. This is how we create the idea that actually the reason you're not getting better is because you have another diagnosis and we need to treat that. The reason you're not getting better is because you actually have treatment-resistant depression. And so we need to now zap your brain with ECT, et cetera, et cetera.
Right. Yeah, it's like, could you, I don't know, diagnose or prescribe discipline or just, self-determination, or just it's time to dig inside you and find the wherewithal to make this happen, because there is no script for me to write you that's just going to change it. You're going to have to do it yourself. And maybe here's some tools or something like that. Here I'm thinking of, just a couple thoughts on that. I was a college professor since 1980. And it was really only like in the last 7 or 8 years that all of a sudden, every semester, I got letters from the psych clinic, whatever, on campus. Here are the students that need special time, help. They don't want to speak up in class. They don't want to participate in debates. They don't want to give a public talk in class. They need extra time for the test and so on. And it was like a quarter, maybe a third, no, maybe I don't know, 20% now. All of a sudden, it's like, but these are the same kids that I've been having. They're normal kids. So they've been kind of pathologized as to having some sort of problem. They must have got this idea in high school or something. And now they just go straight, because I had freshmen, they go straight to the health clinic there on campus and say, I have this problem. And I thought, wow, okay. And so one of them, I tried to work with them because I had each student give a student TED talk. They had to get up and do 18 minutes, and they also had to write essay, just a whole range of sort of critical thinking skills about engaging in ideas. And so I would just tell them, they said, well, I'm really nervous and anxious, about giving a public talk. Yeah, everybody is. That's normal. That's okay. That's good. No, I mean, I can't do it. It's like, yeah, of course you can do it. What? But no, I can't. Yes, you can. Oh, I'll work with you. Come on. We'll practice ahead of time. And they did it. And they're like, huh, yeah, okay. So, I don't know if you know who, one last bit here, Jocko Willink. He's the ex-Navy SEAL. His book is Discipline Equals Freedom. He's sort of a Tony Robbins kind of guy, just do it, the power within and so on. But he's really clever about this. But the whole thing is, I wish I was more disciplined. I want to work out every morning and I just can't do it. What do I do? He goes, just do it. No, I mean, like when I get up in the morning, how do I motivate myself? Just go work out. Well, but isn't there a hack or something? No, there's no hack. Just
No,
get up
there is
and
no
work
hack.
out.
Yeah.
Oh, okay. And then they do it and they're like, oh, okay, I can do this. So maybe some of what you're saying is, we need to teach that. Or I don't know what it's called, resilience or self-discipline or something like that.
But those examples are saying almost there's no need to teach that. It's almost like reminding people, isn't it?
Mm-hmm.
So one of the things that I think is important is the model I have in mind of when people walk into the clinic, when they walk through the door. My starting point is I assume who I'm seeing are experiencing human problems that I will, until I can be proven otherwise, view as within the realms of ordinary and or understandable. I will also assume that people are doing the best that they can in the situation that they found themselves. And finally, I will also assume that they're much more capable than they believe they are. So these things then will shape the types of things that I notice, the types of conversations that I have. So it's very rare for me to tell people to do this or do that or prescribe a strategy. What I'm trying to offer them is a way of thinking about a framework for which to understand. What I call it is models with consequences, the different models, the frameworks that I use to help them understand what's going on, they have consequences. And I'm looking out for those examples of people discovering just what you said, that, so people are saying, how can I get up? I can't get up in the morning at 7 o'clock. Okay. What ideas do you have? Let's visualize it now. What would happen? How are you going to go about it? Because actually, a lot of the time, it's not that complicated. But there's something that's sort of getting in the way mentally, and you're just trying to nudge them in the direction of yeah.
Well, let's just kind of wrap up here and talk about neurodiversity is one of your concepts here, which I like this idea. There's nothing wrong with Elon Musk or Temple Grandin or Steve Jobs or any of these creative entrepreneurs. They're just neurodiverse. All right. But what about the parents who have, I don't know, an autistic kid, or maybe that's not the right diagnosis, but they can't really function on their own? I mean, they're really severely mentally or developmentally disabled. They may need lifelong care. That is that also neurodiversity, or is that something else?
So I'm a critic of the whole concept of neurodiversity. I see that it's kind of a pointless concept. Because by definition, aren't we all neurodiverse?
Yes, I would hope so.
I mean,
yes.
Right. Each one of us is unique. And this is where I see it's all got muddled up with the whole identity politics. We seem to be wanting to develop a typology of human difference, whereas it's just, we are just, take the neuro out, we are just diverse. I mean, So, and this is what I was saying earlier. Once we get absorbed in this concept and we imagine these people who are really have, quite big educational, clinical, social needs, who are at the more severe end, and we imagine that they have the same type of category as somebody right up there as the Elon Musks of this world, it's not going to help us understand. So in many ways, I'm arguing that the concept has got so corrupted that it's no longer telling us anything useful. And there's no shortcut to actually looking at each individual from the point of view of what are their educational needs, what are their social needs, what are their clinical needs.
Right. So you finish up here where I was going to start because when I was in graduate school, we read Michel Foucault's In Madness and Civilization, A History of Insanity in the Age of Reason. I forget the date he put on it, but the opening sentences was something like, mental illness began in 1691, whatever it was.
Yeah.
Like, what?
Yes. Yeah.
I mean, these hunter-gatherer groups didn't have, crazy people.
Exactly. I mean, he's talking about the meaning-making framework. There's a similar one from Philip Aries, who wrote a book, who said that childhood began in something like 17-something.
Right.
Up until then, there were just little adults. I mean, it's an exaggeration of but it's saying that the way, children haven't changed, but what we consider to be childhood has, just in the same way that there's always been distress, there's always been difference, but how we make sense of that's the thing that changes.
So what would you recommend changes for the psychiatric profession? I mean, do we keep the DSM, the Diagnostic Statistical Manual? Would you throw it out completely, or
throw it out?
Throw it out. Okay. And then your colleagues go, all right, well, what do I do then? Somebody presents to me, what I'm supposed to look up. Here's the symptoms. They have 12 of the 18 symptoms. They're in this box. You're saying, don't do that.
Don't start with the idea that they're symptoms for a start.
Oh, don't call them symptoms, you mean?
That's you're already putting an interpretive framework. I think there will always be doctors in the field of distress. I even now think mental health might be too corrupted a concept. I prefer states of mind and talking about distress. When I first started in my first placement in child psychiatry, and why I was very attracted to that, because it just made sense to me, and why I consider myself a traditional child psychiatrist, and that was in 1992, and we didn't do diagnosis in that department. Kids came with problems. We didn't even talk about the person who was coming to us with the problem as the patient. We talked about them as the identified patient. In other words, the idea was that they're bringing forward a problem that's going on. That doesn't necessarily mean the problem is in them, or that our approach is to try and fix something in them. We would always see the family. We'd always think about context. And so there were two things that I learned from that first placement, was the importance of context, particularly with children, because they're not going to make most of the important decisions about what's going to happen in their life, let alone, all of the influences. So you've got the whole resources of family and community, etc. And the second one is development. So the concept of development, just the idea that things change. So these, I thought, were kind of gifts to the rest of psychiatry, in fact, gifts to the rest of medicine, to remember people have contexts, and that as they go through life, change is the one constant. And so I'd want the field of psychiatry to be that philosophical branch of medicine, and understanding that experiences require a different system of knowledge. But we also need to bring our medical knowledge to bear, because sometimes some experiences are symptoms, and we need to be able also to recognize that. Hypothyroidism, Cushing's disease, dementias, there's lots of things where certain experiences and behaviors are actually symptoms.
Maybe the problem is psychiatry is a branch of medicine, and medicine is treating problems. Diseases. So maybe you need to expand the category to be, I don't know, more of these social, cultural factors as well.
Yeah. So I tend to think of healthcare.
Yes. Right. Right.
So medicine is part of healthcare, and psychiatry is part of healthcare.
Yeah. Well, this is the larger point on, medical doctors are not treating sort of the general wellness of patients. They just come, you have 8 minutes to diagnose and solve a particular problem. How about how's your diet? How's your exercise? How's your social life? How's your marriage and how's your job? And, all these other factors that matter. You only got 8 minutes. So you're not going to, that's part of the other part of the problem.
True, indeed. So, although psychiatrists, we do get more time.
You get 50 minutes.
Yeah.
That's much better than 8 minutes, but really 50 minutes. All right, Sami, great book, Searching for Normal. By the way, I love that cover. That's a very clever design. I'm an admirer of book covers, so I really like that.
I do like the artwork that they came up with.
Even the word normal, that's probably also fraught with all sorts of
exactly.
assumptions.
That's where I finished the book by saying that up close, no one is normal. So it was an interrogation also of the concept.
Interesting.
By interrogating the concept of abnormal, I'm also interrogating the concept
of course.
of normal.
Yes. Yeah, right.